I want to talk to you today about what is probably the most prescribed diabetes medication on earth, a tablet that has been in use for well over 60 years, that costs very little, and that remains for most people with type 2 diabetes the first medication a doctor reaches for, metformin. And I want to talk about it because it occupies an unusual position. It is genuinely one of the better medications in the pharmacy with a long track record and real benefits beyond simply lowering a number. And at the same time, there are several things about taking it after 70 that a great many people have never been told. Things about your kidneys, about a vitamin deficiency that develops silently over years, about what to do when you're unwell, and about a rare but serious complication that has a specific and preventable trigger. So today, calmly and in balance, I want to give you the understanding that lets you take this medication safely for many years. So today I'll explain how metformin actually works and why doctors like it so much, the side effects, and crucially, the two simple changes that solve them for most people. The vitamin B12 issue that after 70 genuinely matters, the kidney relationship and why your doctor keeps testing, the sick day rules that prevent the one serious complication, the situations where it needs pausing, and the questions worth asking at your next review. And as always, nothing here is a reason to change what you take on your own. Let me begin with what the tablet actually does. Let me explain how metformin works, because it's rather different from what most people assume. Many people believe diabetes tablets work by pushing your pancreas to produce more insulin, and some do, but metformin does not, and that distinction matters enormously. Metformin does three things. Its main action is on your liver, which, it may surprise you to learn, produces glucose and releases it into your bloodstream continuously, particularly overnight. And in type 2 diabetes, the liver produces too much, so metformin reduces that output. Second, it improves insulin sensitivity, meaning it helps your muscles and tissues respond better to the insulin you already produce. And third, it modestly reduces glucose absorption from the gut. Now, here's the crucial consequence of that mechanism. Because metformin does not force your pancreas to release insulin, it does not on its own cause low blood sugar. That is a genuinely important safety advantage, particularly in older adults, because hypoglycemia is dangerous in this age group, causing falls, confusion, and cardiac events, and it is the main risk of several other diabetes treatments. So, a person taking metformin alone is at very low risk of hypos, whereas a person taking metformin alongside insulin or a sulfonylurea like gliclazide can certainly have them, and that combination is where the risk lies. And metformin has other properties that make doctors fond of it. It's weight neutral or produces slight weight loss. Unlike several alternatives that cause weight gain, it's inexpensive, it has a 60-year track record, and there is evidence of cardiovascular benefit. So metformin works mainly by reducing the glucose your liver makes and improving your body's response to insulin. It does not cause low blood sugar by itself, and that safety profile is a large part of why it remains first choice. Now, the side effects and how to solve them. Let me talk about the side effects because they are the reason a substantial number of people stop taking metformin, and in most cases, they are entirely solvable. The overwhelming majority of metformin side effects are gastrointestinal, nausea, a metallic taste, abdominal cramping, bloating, wind, and, most commonly and most troublesomely, diarrhea. These affect a significant proportion of people starting it, and they are genuinely unpleasant, and they lead many people to abandon the medication quietly. So here are the fixes, and they work for most people. First, take it with food, always, and specifically with or immediately after a meal rather than before, which substantially reduces the gut effects. Second, start low and increase slowly, so beginning with one small dose daily and building up over several weeks rather than starting at a full dose, which allows the gut to adapt. And if you've had trouble in the past, ask whether you can restart at a low dose and titrate more gradually. Third, and this is the fix most people don't know about, ask about the modified release or slow release preparation because it releases the drug gradually and is substantially better tolerated with markedly fewer gut side effects, and switching to it rescues a great many people who could not tolerate the standard version. That single question, could I try the slow release form, has saved countless people from abandoning a good medication. Beyond the gut, the other side effect worth knowing is the metallic taste some people report, which usually settles, and I'll come to the B12 issue separately because it deserves its own section. So the gut effects are common, real, and usually fixable with food, slow titration, and, above all, the modified release preparation. Now, the deficiency that develops silently. Here is the issue that after 70 genuinely matters and that a great many people on long-term metformin have never had checked: vitamin B12 deficiency. Metformin interferes with the absorption of vitamin B12 in the small intestine, and this is not a fringe theory, it is well established, and the risk increases with higher doses and longer duration of use. So somebody who has been on metformin for 10 or 15 years is at real risk. And here is why it matters so much in this age group. B12 deficiency causes fatigue and anemia, but more importantly, it causes neurological damage, tingling, numbness, and burning in the feet and hands, balance problems and unsteadiness, and memory, concentration, and mood changes. And now, consider the trap because it is genuinely cruel. A person with diabetes who develops tingling and numbness in their feet is very likely to have it attributed to diabetic neuropathy, which is an entirely reasonable assumption since diabetes is the leading cause of neuropathy, and so the B12 is never checked and the deficiency continues for years. And the crucial point is that B12-related nerve damage is largely reversible if caught early and can become permanent if left, whereas diabetic neuropathy is managed rather than reversed, so the distinction genuinely changes the outcome. And there's a second trap worth knowing: if the person also takes an acid-reducing medication like omeprazole, as many older adults do, that further impairs B12 absorption, so the two together compound the problem. So what should you do? Simply this: if you have been taking metformin for more than a few years, ask your doctor to check your vitamin B12 and ask again periodically, perhaps annually, and ask sooner if you have any tingling, numbness, unsteadiness, or unexplained fatigue. It is a cheap, simple blood test, and correcting a deficiency is straightforward. So long-term metformin depletes B12. The resulting nerve symptoms are routinely misattributed to diabetic neuropathy. The damage is reversible if caught early, and the test is simple and should be asked for. Let me talk about your kidneys, because this is the relationship that governs how metformin is prescribed after 70. Metformin is cleared from your body by your kidneys, and it is not metabolized by the liver, so if kidney function declines, metformin accumulates. And kidney function declines with age in almost everyone, gradually and normally, which is why your doctor checks a blood test called eGFR, a measure of how well your kidneys are filtering at least annually and often more frequently. Now here's what that means practically. Above a certain level of kidney function, metformin is used normally. Below that, the dose is reduced, and below a lower threshold, it is stopped because the risk of accumulation becomes unacceptable. Your doctor knows those numbers and applies them, and the reason I'm telling you is so that you understand why the blood tests matter and why your dose may change over the years, even though nothing about your diabetes has changed. Please attend those tests because they are the safety system for this medication. And why does accumulation matter? Because of the rare but serious complication I mentioned, lactic acidosis, in which lactic acid builds up in the blood. Let me put this in proper proportion because it frightens people unnecessarily. Lactic acidosis with metformin is genuinely rare, and it essentially does not occur in people with normal kidney function taking appropriate doses. It occurs when something else goes wrong, most often a sudden decline in kidney function, severe dehydration, a serious illness, heart failure with poor circulation, or heavy alcohol use. So the risk is not really the tablet, it is the tablet plus a situation, and that is precisely why the sick day rules exist, and they are the most useful practical knowledge in this entire video. So metformin is cleared by the kidneys, the annual blood test governs the dose, and the rare serious complication happens when something else goes wrong, which is what the sick day rules protect against. Here are the sick day rules, and I want you to remember them because they prevent the great majority of problems with this medication. The situations that matter are these: any illness causing vomiting or diarrhea, any fever or serious infection, any illness where you cannot eat or drink normally, severe dehydration, and hot weather where you're sweating heavily and not drinking enough. In all of those, two things happen at once. You become dehydrated, which reduces blood flow to your kidneys and temporarily impairs their function, and metformin, still being taken, begins to accumulate. That combination is the setup for trouble. So, the widely used guidance, and I want you to confirm this applies to you personally with your own doctor in advance, is that metformin should generally be paused during acute illness with vomiting, diarrhea, fever, or an inability to eat and drink normally, restarting when you have been eating and drinking normally for a day or two, typically after 24 to 48 hours. Metformin is on the standard sick day medication list alongside the blood pressure medications and diuretics I've discussed in other videos. And the reason these lists exist is that this scenario, an ordinary stomach bug in an older person on several medications, is one of the commonest routes to a preventable hospital admission. So please have this conversation at a calm appointment rather than in the middle of a bug, and ask directly: if I get vomiting, diarrhea, or a fever, should I pause any of my medications? For how long and when should I call you? And write the answer down and keep it somewhere findable. And one more crucial situation: if you are having a scan with contrast dye, particularly a CT scan or certain X-ray procedures, your metformin may need to be paused around the procedure because the dye can temporarily affect kidney function. So always tell the radiology department and your doctor that you take metformin and follow their specific instructions. Likewise for surgery. So pause during vomiting, diarrhea, fever, or dehydration as agreed with your doctor. Restart when eating and drinking normally, and always declare metformin before contrast scans and surgery. Let me give you the practical points for daily use. First, take it with food, every dose, which reduces gut upset and is the single most useful habit. Second, be consistent and use a pill organizer if you take several medications because diabetes control depends on regular dosing. Third, if you miss a dose, take it when you remember if it's reasonably close to the time, but skip it if it's nearly time for the next one, and never double up. Fourth, alcohol. And this deserves emphasis because heavy alcohol use increases the risk of lactic acidosis and also of low blood sugar, particularly if you're on other diabetes medications. So moderation genuinely matters here more than with most tablets. Fifth, understand what metformin is and isn't doing, because it lowers blood glucose, but it is not a substitute for the things that actually treat type 2 diabetes at its root, which are diet, weight, and physical activity. And I'd point out that exercise improves insulin sensitivity through a mechanism that works alongside metformin, and that even modest weight loss can substantially improve blood sugar control, with meaningful weight loss capable of putting type 2 diabetes into remission in some people. So, the tablet is a support, not a permission slip. Sixth, if you take metformin with insulin or a sulfonylurea like gliclazide, know the symptoms of low blood sugar, shakiness, sweating, hunger, confusion, and irritability, and always carry something sugary, and be aware, as I mentioned in my beta blocker video, that beta blockers can mask those early warning signs. And seventh, keep your feet, eyes, and kidneys monitored because those are the complications of diabetes that matter, and they're detected by screening long before you'd notice anything, and the annual eye screening and foot check are among the most valuable appointments in senior health. So take it with food, be consistent, moderate the alcohol, remember it supports rather than replaces diet and activity, and attend the screening appointments. Let me talk about the wider question of diabetes targets after 70 because this is something people are rarely told and it can be reassuring. Blood sugar targets are not the same for everyone, and in older adults, particularly those who are frail, have several other conditions, or have a limited life expectancy, guidelines increasingly recommend less aggressive targets. The reasoning is straightforward. The benefits of very tight blood sugar control accrue over many years, mainly by preventing eye, kidney, and nerve complications in the long run, whereas the harms of tight control, principally hypoglycemia with its falls, fractures, and cardiac risks, are immediate. So it is entirely appropriate and increasingly common for a doctor to relax the target for an older person. And if your doctor suggests that your HbA1c target can be a little higher than it used to be, that is not neglect, it is good individualized medicine. And relatedly, there is growing attention to deprescribing in older adults with diabetes, meaning carefully reducing or stopping medications that are no longer providing net benefit, particularly the ones that cause hypos, and that too is a legitimate and thoughtful part of care. So it's worth asking at your review, what is my target? Is it right for me at my age? And are all my diabetes medications still earning their place? So targets should be individualized after 70. A relaxed target is good medicine rather than neglect, and deprescribing is a legitimate conversation. Let me be very clear about when to contact your doctor. Seek urgent medical attention for the symptoms of lactic acidosis, which are unusual and severe muscle pain or weakness, difficulty breathing or unusually deep and rapid breathing, severe drowsiness or confusion, feeling very cold, unusual stomach pain with nausea and vomiting, and a slow or irregular heartbeat. And while this is rare, particularly if these develop during an illness or dehydration, they need immediate assessment. Seek same-day advice if you are unwell with vomiting or diarrhea and are unsure whether to pause your medication, because that is exactly the moment the sick day rules apply. Contact your doctor promptly for persistent gut side effects that are affecting your life, and ask about the modified release preparation for tingling, numbness, burning, or unsteadiness in the feet or hands, and ask specifically for a B12 check for unexplained fatigue, for symptoms of low blood sugar if you take other diabetes medications too, and before any scan with contrast dye or any surgery. And attend your routine appointments, the kidney blood tests, the HbA1c, the annual eye screening, and the annual foot check, because those are how problems get found early. So, severe muscle pain, breathing difficulty, and confusion need urgent care. Illness raises the sick day question, gut side effects and nerve symptoms need a conversation, and the routine tests are the safety net. Let me paint you a picture. Picture a man of 76 who has taken metformin for 14 years and manages his diabetes reasonably well. Over the past 2 years, he has developed pins and needles and a burning sensation in both feet, which his doctor and he both assumed was diabetic neuropathy, which is by far the most likely explanation and a completely reasonable one. He's also become a bit unsteady, which he put down to his age, and rather tired. At a routine review, a new doctor looking at his long medication history asks a simple question: when was his B12 last checked? And the answer is never. It comes back significantly low, which is unsurprising after 14 years of metformin plus the omeprazole he's also been taking for years. Treatment stops the progression and improves his energy and some of the tingling, though not all of it because some of the nerve damage had been there too long. Now, the point of that story is not that metformin is bad. It is a good medication that has been managing his diabetes well for 14 years. The point is that one cheap blood test done years earlier would have prevented an entirely avoidable and partly irreversible problem. Contrast that with a woman of 72 who catches a norovirus-type stomach bug, spends 36 hours vomiting, and, because she had asked the sick day question at a calm appointment 2 years earlier and had the answer written on a card in her kitchen drawer, pauses her metformin and her blood pressure tablets, sips fluids, calls the surgery for advice, and restarts everything 2 days later when she's eating normally again, nothing whatsoever happens to her, which is the entire point. Two people, two ordinary situations, and in both cases, the difference was information nobody had given them until somebody did. And let me speak briefly to those caring for an older parent or partner. Make sure the sick day plan exists and is written down somewhere findable because nobody remembers advice while they're vomiting, and this is genuinely the highest value thing you can do about this medication. Ask when their B12 was last checked if they've been on metformin for years, and connect the dots if they have tingling feet, unsteadiness, or fatigue because that connection is missed constantly. Make sure the annual blood tests, eye screening, and foot checks actually happen, since these are the appointments most easily missed and the most valuable. If they've stopped taking it or take it erratically because of stomach upset, which is extremely common and rarely admitted, raise the modified release option with their doctor and make sure the radiology department knows about metformin before any scan with contrast. And watch during any illness for the dehydration spiral because an older person with a stomach bug on several medications is a genuinely vulnerable situation. So let me draw this all together calmly. Metformin reduces the glucose your liver produces and improves your body's sensitivity to insulin. And because it does not force insulin release, it does not by itself cause low blood sugar, which is a significant safety advantage after 70 and part of why it remains first choice. Its gut side effects are common and unpleasant, but usually solvable. With food, slow dose increases, and above all, the modified release preparation that so many people are never offered. Its most important long-term issue in this age group is vitamin B12 depletion, which develops silently over years, causes nerve and memory symptoms that are routinely misattributed to diabetic neuropathy and aging, and which is found by a cheap blood test that should be asked for. It is cleared by the kidneys, which is why the annual kidney blood test governs your dose and why that appointment matters. And the rare serious complication, lactic acidosis, is essentially a complication of situations rather than of the tablet, which is why the sick day rules, pausing during vomiting, diarrhea, fever, or dehydration, and declaring metformin before contrast scans and surgery are the most valuable practical knowledge here. So here's what I'll leave you with, straight and clear. First, take every dose with food, and if your stomach has never tolerated it, ask about the slow release version rather than quietly giving up. Second, if you've been on metformin for more than a few years, ask for your vitamin B12 to be checked and ask again if you have any tingling, numbness, unsteadiness, or fatigue, because that is the single most under-requested test in this whole topic. Third, get the sick day plan agreed in advance and written down, and always tell radiology and surgical teams that you take metformin. Fourth, attend the routine monitoring, the kidney tests, the eye screening, and the foot check, because those catch the things that actually cause harm in diabetes. And fifth, ask at your review whether your blood sugar target is still right for your age and circumstances, because targets should be individualized after 70, and a slightly relaxed one is often better and safer medicine. Metformin is a genuinely good medication, and taken with these few pieces of understanding, it does its job quietly for decades. So take care of yourself, take it with your meal, ask about your B12, write down your sick day plan, and keep those appointments. And because doses, pauses, and any change to diabetes treatment belong entirely with your prescriber, please treat every question here as a conversation with your own physician. Treat illness with vomiting or diarrhea as the moment to seek advice about pausing, and treat severe muscle pain, labored breathing, or confusion as your reason to seek urgent medical care.